All right, so today we're going to be talking about carpal tunnel syndrome with Dylan, Riley, Anna, and myself. So to start us off, carpal tunnel syndrome occurs when the median nerve becomes pressed or squeezed at the wrist. It is characterized by sensory loss and motor weakness, and nerve damage can occur in more serious cases. The etiology of the symptoms are multifocal with local and systemic factors, and Riley will get more into the pathology of it in a second. So we're going to use a dynamic system theory approach, and we're using a conservative approach as well with that. So we're trying to avoid surgery. And post-intervention, we're hoping to decrease pain, increase function, and increase strength.
So the flexor retinaculum and the carpal bones are what make up the carpal tunnel, and the 9 flexor tendons are what are going to run through it, and the median nerve as well. We know that there is a lot of idiopathic risk factors that can lead to carpal tunnel syndrome, such as like gender, age, genetics, and also anthropometric factors. So that's like the size of your carpal tunnel. Females generally have smaller carpal tunnels, so it's more likely to have that compression. There's also occupational risk factors, jobs that require repetitive tasks, force, posture, and vibration are going to put someone at higher risk. And then also carpal tunnel syndrome in diabetic patients may also stem from internal factors that are going to cause nerve damage like hyperglycemia and deficiency of neurotropic factors such as nerve growth factor. Get the next one. Sweet. So basically, carpal tunnel syndrome is caused by compression and traction of the nerve. We're going to see a loss in flexibility of the ligaments. There's going to be less fluid movement, which is going to cause an increase in pressure in the tunnel, which causes ischemia of the microvessels surrounding the nerve, which increases inflammation and edema. We're going to see a stiffening of the connective tissue, which makes it difficult for the nerve to move. And when it doesn't move as well, it's going to expose the nerve to like shearing forces. And then this can lead to lesions. Demyelination is going to be caused by compression. We're going to see an increase in collagen fiber size, in fibroblast density, and type 3 collagen in the synovial connective tissue. So in the end, we're going to get some scar tissue around the median nerve, and we're going to see the synovial tissue thicken at the entrance and exit regions where the tendons slide over the flexor retinaculum. So these are really what are going to cause the nerve damage and the pain.
All right, so some impairments is increasing pain and paresthesis in the hand with repetitive use, weakness or atrophy in the thenar muscles in the first 2 lumbricals. So in the first top picture, the purple is the median nerve distribution, if you don't recall from anatomy. And then you can have possible decreased joint mobility in the wrist and metacarpal familial joints. And if you think about it, if you're not using it because you have less muscle, sensory, you lose it. And then in the bottom picture, you can see the atrophy of the thenar muscle. And then you can have sympathetic nervous system changes as the nerve runs with your blood vessels. And some functional impairments is you have decreased precision in tip-to-tip, tip-to-pad, and pad-to-pad. And with that, you have difficulties with activities requiring fine neuromuscular control of the thumb opposition, such as buttoning your clothes. And you have avoidance of the areas that have decreased sensation. And you have inability to perform provoking, sustained, or repetitive wrist or finger motions, so such as assembly line, cashier, hairstylist. So it can affect jobs and ability to work, and it can also have sleep disturbance. So Anna's going to get into our exercise program for us.
Okay, so the exercises that were the most supported by the literature for conservative approach to treating carpal tunnel were tendon and nerve gliding exercises. These were proposed by Totten and Hunter to reduce scar adhesions and maximize nerve excursion, and they've also been shown to reduce edema, improve venous return, and reduce pressure in the tunnel, all of which will improve the symptoms. So it's basically this series of hand positions, and the top ones are the nerve gliding and the bottom are the tendon. So you're going to have the patient hold each position for 5 seconds, And you want to repeat that 10 times during a session and try to do 5 sessions per day. And you'll continue this for 3 weeks. And this should be modified or decrease the dosage if the patient has any intense pain in any of the positions. Next, we have some stretches. So the idea behind this is reducing nerve entrapment because the neck and wrist are very common locations for that to happen and can cause carpal tunnel syndromes. So we want to stretch the upper trapezius, levator scapulae, scalenes, wrist flexors, and wrist extensors. Hold each for 30 to 45 seconds at least and repeat twice per day. And again, decrease if the patient has any intense pain while stretching. Finally, after we've reduced their pain significantly with those other exercises, we're going to want to do some strengthening to avoid muscle atrophy. So you're going to have them grab a small weight or even a resistance band and do some flexion, extension, pronation, supination, and then also radial and ulnar deviation. Because this is for endurance, we want to do 2 to 3 sets, 12 to 20 reps of each motion, and repeat that a couple times throughout the day. We also want to strengthen their hand and fingers. So I found this finger strengthening tool on Amazon, but if they don't have one of those, they can use a stress ball or anything squishy to provide some resistance. Same thing, 2 to 3 sets, 12 to 20 reps, and they can progress to a heavier resistance as their hand and fingers get stronger. The point of this is to increase that endurance, so if they're doing repetitive tasks for their work, they will have the ability to do that. And again, decrease if they have any pain or symptoms reproduced with these actions.
So probably the most common position that people often get carpal tunnel syndrome is sitting at a desk and working at a computer. And I think this is what a lot of us associate carpal tunnel with. So as you can see in the picture, there's a few different postural changes you can do that will help you not compress your median nerve. So if you're resting your wrists on your desk, it's just pushing on that nerve the entire time that you're working. So if you lift your hands up, it takes the pressure off of the nerve. Additionally, having good posture when you're sitting, so have a straight backed chair, and then make sure your monitor is sitting at the correct height. All right, and then we have a few tests and measures here to determine the severity and or presence of carpal tunnel syndrome. So we have Tinel's test, which is basically just tapping right here, and if they feel nerve symptoms such as tingling, pins and needles, then that's a positive result. And then Phelan's test is flexing both wrists and then holding this for 1 minute. And if the patient has more nerve symptoms, again, then it is also a positive result. And then we have 2 questionnaires here. We have the Boston Carpal Tunnel Questionnaire, the BCTQ, and this is 19 questions relating to carpal tunnel syndrome symptoms and carpal tunnel related impairments. So these are just kind of general questions for how it's impacting their life. And then a bit more specifically, there's the Michigan Hand Outcomes Questionnaire, the MHQ, and this has 37 questions with 6 categories, and these span from overall hand function to things that they do day to day, their overall discomfort level, how it's impacting their work, how it's impacting their overall aesthetics, their hands, if their hand is looking different due to atrophy, and then overall patient satisfaction. All right, and here are our references. Let us know if you have any questions.